soaring high and making difference, where we talk anything about nursing. So let your voice be heard right here. Moments with Professor X. Good morning, everybody. How are you? How's everybody? My God, I am back again. Today is actually July 17, 2025. And would you believe it's 1 o'clock in the morning, my time? I can't sleep. So I decided to turn on my computer, turn on the camera, turn on the lights, close the door, and do Facebook Live just to make my time productive. So I can't sleep. And I decided to just move on with the topic. I know I uploaded a video yesterday and we talk about cardiac catheterization. And I told myself, no, I'll just move forward and we'll talk about open heart surgery. So we will talk about coronary artery bypass grafting. Anyway, good afternoon in the Philippines. Good morning here in Las Vegas. My God, we have a couple of viewers today. It's early in the morning. Okay, hello to Vincent J. Kabudoy. Thanks for watching. Guys, you know what? You have to sleep. And just a heads up to all my students right now in the Philippines. You can watch this video later on if you have time. You can replay, play, pause, download the video, and then watch it later on. If you have any concerns or questions, please drop a message or send a private message to me, and then I can answer whatever queries or concerns you have. What else? Who do you have here? Hello to Mitzi Hamero. Thanks for watching. And Renz Marion Viloria. Thanks for watching as well. Renz Marion. Sounds familiar. Anyway. So let's talk about coronary artery bypass grafting. And then I will highlight possible questions that will come out in your qualifying examination. Okay? Let me share my screen and from there, let's move forward. Okay. Before I start, hello to Hides Hametika. Thanks for watching. So again, we'll talk about CABG or coronary artery bypass grafting. So let's write it down. Okay, your CABG stands for coronary artery bypass grafting. So what is this? This is actually one of the treatment modalities to patient with coronary insufficiency. It means to say that the coronary artery of the patient is actually occluded or obstructed, and because of that issue, coronary occlusion, it disrupts the normal flow of blood supply to the heart. Okay, so if you can still remember, for example, that this is the coronary artery, just an example. Okay, let's say that this is the coronary artery, and there is a clot inside the vessel. So what happens is that because of an occlusion or a clot, an emboli, blood flow is impossible. Okay, because of a complete obstruction. Okay, so blood flow is impossible. So what will happen to the cells distal to that? So the cells distal to the occlusion will die because they will be deprived of enough or good blood supply. Okay, and we don't want that thing to happen, because when these cells die, remember the primary structure, the heart as a primary structure is mainly made up of a cardiac muscle tissue. And take note that the primary function of the heart is to pump the blood out. So come to think of it, if you deprive the heart of a good blood supply, you injure the heart muscles, and the heart muscles no longer contract. Okay, because of a coronary occlusion. So that is where your CABG kicks in. Okay, so your coronary artery bypass graft is a procedure wherein the doctor uses a blood vessel from part of the body, and then the doctor will attach that into your, so this is your aorta, connect that to the distal part of occlusion. Okay, so it means to say it bypasses the area with obstructions. If the blood is not possible to pass here because of occlusion, you don't have to worry, because this cabbage or coronary artery, this is a new way, a new passage for the blood to pass, okay, to flow in order to supply the blood, okay, in order to supply the cells or tissue distal to occlusion. So that's the main objective of your cabbage, okay? Now, why do we have coronary occlusion? Now, remember, in your examination in your NCLEX, sometimes you'll be asked in your select all that apply about the risk factors for coronary artery disease. Let's try to discuss this before we proceed with cabbage discussion. Coronary artery disease, or CAD. Okay. Now, when I say risk factors, technically, risk factors are divided into two. So there's such thing as what we call modifiable and non-modifiable. Okay. Non-modifiable, and then you have your modifiable risk factors. What's the difference? It's very simple. When you say modifiable risk factors, these are things or factors that can be modified, that can be altered, that can be changed, okay, in such a way that if you do some modification, it decreases your likelihood to develop the problem or to develop coronary artery disease. When you say non modifiable risk factors, these are factors that are innate, present, okay, to your patient. You cannot do something about it because it's innate, it's non-modifiable, okay, which will increase your likelihood to have or develop coronary artery diseases. Now let's identify non-modifiable. Number one is age. Can you change your age? No. Okay. Now what specific age group, okay, has a higher risk for coronary artery disease? Okay, risk for heart attack. Of course, those who are older than 50 years old. Okay, older than 50. Oh, by the way, just a little break. We have some greetings here. Hello to Banjit. Thanks for watching. Brian Leses, thanks for watching as well. Hello to Stephanie Jean Supremo. Thanks for watching. Danvi Beharin. Thanks for watching as well. And Danvi Beharin said, pass my NCLEX with your EKG class, sir. Oh, congratulations. I'll give you a round of applause for that. There you go. Congratulations for passing the examination. Really, what part of my discussion helped you passing or conquering the examination? Let me know. Okay. And if you can share what specific topic came out, if you can still recall what, okay, the specific questions or topics or diseases that came out in your examination. Anyway, let's move. Let's go back. So non-modifiable risk factors: age. Number two, gender. Okay, gender. It's common to men than in women. Okay, but again, I'm not saying that if you're, if you're a lady, women won't have heart attack. Okay, it's just that it's common to men. Okay, next, number three, another non-modifiable is race. Do not forget this race. This usually comes out in the examination. What specific race has a higher chance, higher risk for stroke, higher risk for heart attack, higher risk for what is hypertension? Don't forget African American. Okay, African American. I guess I remember, when was it? Was it last year or 2 years ago? I was having my African American. I was having my NCLEX class, and then the same topic, and then I asked the group, what specific race has a higher risk for stroke? Was it stroke or heart attack? The topic, but anyway. And then I asked him African American, and they asked me African. No, I'm not. You're not supposed to choose between African or American. It's African American. Okay. Anyway, so non-modifiable risk factors. So you have your age, gender, race, and of course, don't forget it runs in the blood. Genetics. Okay, genetics, or you call this a sure heredofamilial. It has a familial tendency. Okay, these are your non-modifiable risk factors. Now, what about modifiable risk factors? Remember, I said modifiables, these are things that can be changed, that can be altered in such a way that if you do stuff, okay, if you modify, then it will decrease your likelihood to have heart attack. Okay. So, what are modifiable risk factors? Of course, number one, diet. So, here we go. Guilty. Okay. Diet. What specific diet increases your risk to have heart attack? We often hear this. Of course, those who eat fatty foods, high fat, correct? What else? High sodium. Remember, if you eat high fat, high sodium increases the risk of hypertension. Okay. Now, what else? Of course, high carb. Okay. Carbohydrates. Okay. And take note, you eat a lot, but you don't burn them. You don't exercise. So that's another modifiable risk factor, your lifestyle. And what is that? Sedentary lifestyle. You don't exercise. Okay, another modifiable risk factor is hypertension. Oh, it's modifiable, yes. Okay, that's why you have to okay, you have to exercise, dietary modification. Number four, another modifiable is smoking. Don't forget that. Number five, remember, if you love to eat fatty foods, expect that another modifiable risk factor will have hyperlipidemia. Hyperlipidemia. What is this? It means to say that you have a high lipids or cholesterol in the blood. Okay. What else? Smoking, hyperlipidemia, patient with diabetes mellitus. Okay. If you can still recall, your diabetes mellitus has several complications. Okay. There are three major complications of your diabetes mellitus. And what are these? First, diabetes mellitus can cause a condition called, uh, what do you call this? It can cause neuropathy. Okay, neuropathy. So you say neuropathy, there will be damage, injury in your nerves. That is why patient with diabetes mellitus sometimes they complain numbness, paresthesia, and sometimes it affects patient sensation. You'll be surprised if you're walking and then there's numbness in your lower extremities, and then accidentally you step on something that is sharp, and since there is decreased sensation, you won't feel any injury or any pain. There's no pain in it. So what will happen? It increases your likelihood to have physical injury because of decreased sensation, secondary to neuropathy. Okay. Another complication of diabetes mellitus is what we call macroangiopathy. So when you say macroangiopathy, there's an injury in the large blood vessels. Okay, why? Because of a persistent elevation in the patient's blood glucose, your hyperglycemia. Now, why is your patient hyperglycemic? It's related to an issue with your insulin. Okay, now let's go back. Now, in your macroangiopathy, I said it affects large blood vessels. Where? Large blood vessels in the brain, large blood vessels in your heart. That is why a patient with diabetes has a higher risk for stroke and a higher risk for heart attack. Okay. And the third complication of diabetes mellitus is your microangiopathy. Micro is small, macro is big. So we say microangiopathy, there's damage or it affects an injury in your small blood vessels in the eyes, small blood vessels in the kidneys. That is why a patient with diabetes mellitus, another complication is diabetic retinopathy. It causes blindness. It will also cause diabetic nephropathy, damage in your kidneys. That nephropathy is secondary to microangiopathy. Okay. So there are several complications attributed to diabetes. So again, there are three major complications: neuropathy, macroangiopathy, and microangiopathy. That is why if you're diabetic, if you have diabetes mellitus, make sure that you control your blood sugar. Okay. Next, another modifiable risk factor, number seven, stress. Okay, I know, me too. Stress reduction is essential. So another modifiable risk factor, let's check. So you have your diet, sedentary lifestyle, hypertension, smoking, hyperlipidemia, diabetes mellitus, stress. Did I miss something here? Oh, and by the way, patient taking oral contraceptives. Do you know that if your patient takes oral contraceptives, okay, please don't forget this, put an asterisk in number 8, it's common in your examination. If your patient takes oral contraceptives, especially if the oral contraceptive contains estrogen, okay, an estrogen hormone, it increases clot formation. Okay, that is why be mindful if your patient is taking oral contraceptive and suddenly complains calf pain. Okay, calf pain may also indicate deep vein thrombosis, or patient suddenly complains chest pain or shortness of breath, so may be related to clot. Okay, pulmonary embolism, or patient having angina, or patient may an indication of patient having heart attack. Okay, so these are common modifiable risk factors. So try to analyze. So with all these risk factors I mentioned, and you did not do anything about it, keep doing your vices. You keep eating high fatty foods. You don't exercise. What will happen to your coronary arteries? Coronary arteries. Look. So let's say that this is the coronary artery. Okay. With all those risk factors I mentioned a while ago, modifiable and non modifiable, you didn't do anything about it. So let's start to dissect the coronary artery. Let's move a little bit closer. Let's get inside the vessel. So this is the tunica intima that's inside the blood vessel of your patient. With all those risk factors, they will lead to narrowing or occlusion of the blood vessel wall, secondary to fat deposition, hardening of the blood vessel. Okay, so you call that condition there as your as your atherosclerosis. So look, because of that fatty deposits, okay, the blood flow will be affected because of the narrowing of the lumen. Okay. So that is where your cabbage kicks in. That is also where your coronary angioplasty kicks in. Remember, before this video, I uploaded cardiac catheterization. Okay. Remember, in your cardiac cath, the doctor inserts a catheter with a balloon tip catheter, and then as the catheter inflates, it will compress and open the blood vessel of the patient. And sometimes they also pair that angioplasty, the balloon tip catheter, with a coronary stent. Okay. So anyway, so that is your atherosclerosis. Now let's go back to your cabbage. So again, your cabbage or your coronary artery bypass graft, as mentioned a while ago, this is a procedure uh, wherein the doctor uses blood vessels from other part of the body in order to reperfuse the heart. Now, that is why another common question in your examination about cabbage: what are common blood vessels used? Okay, tell me. What are common blood vessels? Blood vessels used in your bypass grafting. Okay, there are two common vessels used. First is the mammary artery. Okay, the mammary artery. And the second common blood vessel used for bypass grafting is your saphenous vein. Saphenous vein. They can also use other blood vessel in the thoracic area. Okay, but again, these are two common vessels used. Okay, so I have an animation here, and this animation will reinforce the things I said. Okay, try to listen, and I hope you learn something. Nope, not that one. The other one.
A coronary artery bypass graft, or CABG, is performed to improve circulation to the heart muscle in people with severe coronary artery disease. In this procedure, a healthy artery or vein from another part of the body is connected or grafted to the blocked coronary artery. The grafted artery or vein bypasses the blocked portion of the coronary artery, carrying oxygen-rich blood to the heart muscle. One or more coronary arteries may be bypassed during a single operation. Before the surgery, an intravenous line will be started, and you may be given a medication to help you relax. CABG procedures are done under general anesthesia, which will put you to sleep for the duration of the operation. A breathing tube will be inserted through your mouth and into your throat to help you breathe. A catheter will be placed in your bladder to drain your urine. Coronary artery bypass surgery generally takes 3 to 6 hours. During a conventional bypass surgery, your surgeon begins by making an incision in the skin over your breastbone or sternum. He or she will then cut the sternum and move your rib cage in order to get to your heart. Throughout the procedure, your circulatory system will be connected to a cardiopulmonary bypass pump or heart-lung machine. This machine temporarily performs the functions of your heart and lungs during the surgery, allowing your heart to be stopped while the surgeon sews the grafts into place. One of two blood vessels is typically used for the grafts: the internal thoracic artery in the chest or the saphenous vein in the leg. For the internal thoracic artery graft, your surgeon will leave the upper end attached to the subclavian artery and divert the lower end from your chest wall to your coronary artery just beyond the blockage. Your surgeon will then sew the graft into place. For the saphenous vein graft, your surgeon will suture one end to the aorta and the other end to the narrowed artery just beyond the blockage. With the graft securely in place, your surgeon will use electrical signals to restore the heartbeat and attach a temporary pacemaker to the heart. Once your heart is again beating normally, the heart-lung machine will be disconnected. Your surgeon will wire the breastbone back together and suture the skin incision closed. A temporary drainage tube will be placed through the skin beneath the incision. Two other types of CABG procedures have recently been developed: off-pump and minimally invasive bypass surgery. Off-pump CABG is also called beating heart bypass grafting because the heart isn't stopped and a heart-lung machine isn't used. Instead, a mechanical device is used to steady the part of the heart where grafting is being done. Surgeons perform minimally invasive bypass procedures using specially designed instruments inserted through small incisions or ports in the chest. These procedures sometimes require a heart-lung machine. After surgery, you will be taken to the intensive care unit. The activity of your heart will be carefully monitored. If necessary, the pacing wires will be used to temporarily control your heart rate. The chest tube will remain in place to drain excess blood and air from the chest cavity. Once you can breathe on your own, your breathing tube will be removed and replaced with an oxygen mask. The bladder catheter will remain in place. As you recover over the next 3 to 4 days, all of these devices will be gradually removed.
Okay, there you are. We're done. So that is what we called bypass grafting surgery. Okay. Now there, I have a video here that where it's an actual, a real bypass grafting surgery, but I will not show it because it's really graphic and bloody. So just a heads up. So anyway, so that's your bypass grafting. Now, if you listen attentively, she mentioned about chest tube. Now, I want to stress something about that. Now, why do doctors insert chest tube after bypass grafting surgery? What's the purpose of that? Hey, now what is the purpose of your chest tube post heart surgery? Anyway, let me check if you have any questions. Now, remember that it's an open heart surgery. Okay. Now, doctors insert chest tube right after surgery because there is a risk of, yeah, correct, Laarni, very good, to drain the fluid out. Not only to drain the fluid out, it will also drain blood or drain, okay, remove air. Since an open heart surgery, there is always a complication of hemothorax. Hemothorax is blood in the pleural space. There's always a complication of bleeding. Okay. There's always a complication of pneumothorax, it's air in the pleural space, or a combination hemopneumothorax. And one more thing, remember during recovery time, post open heart surgery, there is a chance that fluid surrounds the heart. Okay, so analyze. If this is your heart and during recovery time, fluid surrounds the heart. So what will happen? As fluid accumulates, builds surrounding the heart, it will restrict the normal pumping mechanism. It will restrict your heart because of fluid accumulation surrounding the structure. Now, if that happens and not corrected, as fluid accumulates, the heart will not pump well. Okay, if the heart will not pump well, the blood will not be circulated, and that will result to shock. Okay, because of a decrease in the cardiac output, uh, secondary to obstructive shock. Okay, now that is why to prevent that problem, you need to put the drain. You need to put a chest tube. By the way, the medical term for accumulation of fluid surrounding the heart is what we call cardiac tamponade. Okay, so again, the reason why doctors put chest tube is to prevent cardiac tamponade, okay, to drain the fluid out. Okay, I hope that is clear. Now let me share again my screen and let's focus on your nursing responsibilities. Okay. So what are the things you need to remember in your examination when you talk about CABG or post open heart surgery, okay, in general? So here, let's write, okay, nursing responsibilities. Or things to remember, nursing responsibilities post open heart surgery. Post open heart surgery. Please bear. Okay. Of course, number one, take note. Right after surgery, we need to transport patient. Okay, we need to transport the patient from the OR to the PACU, going to the coronary intensive care unit. Okay, remember your PACU or post anesthetic care unit just beside the OR. Now take note. How many personnel are supposed to transport the patient? Minimum of two personnel. Okay, and take note in your examination who decides that the patient is ready for transport. Okay, is it the surgeon or the anesthesiologist? And this is a question in your exam. Who decides whether the patient is ready for transport? Take note, it is the anesthesiologist who will decide whether the patient is stable enough to be discharged to other floor or to be transported. Do not forget that in your exam. But during the surgery, it is the surgeon who will be the leader or the lead doctor during the procedure, during the surgery. But it is the anesthesiologist who will decide, give clearance whether the patient is ready for transport. Don't forget that. Okay, next, number two. Now, take note, you are the nurse in the coronary intensive care unit. Now, here's the question. You will receive a patient post open heart surgery. What are your priorities? What is the first priority, second priority? These are questions in your exam. And take note, they must come in order or in correct sequence. Okay? So let's write it down. Number two, priorities. Okay. So, what will be your first priority, your second priority, your third priority, and then you have your fourth priority? Okay. And we also have fifth priority, the fifth thing to do. Your first priority, the moment you receive the patient post open heart surgery, is to check respiratory functioning. Okay? Do not forget this. Why do you have to check for respiratory functioning? Remember, the patient just had a major surgery, and because of the local, not local, because of the general anesthetic agent, because of the medication given during surgery, it will depress the normal respiratory functioning of your patient. Make sure that the respiratory functioning is intact and, of course, effective. Okay, when you say intact and effective, how will you check for respiratory functioning? Make sure that the patient's O2 saturation are not are is within limits. Okay, check the airway of your patient. Very good one, Josep. Airway of your patient. Remember, during surgery, you depress the normal coughing reflex. Okay, so that is why check for the airway that there are no mucus accumulation. That is why you have to give pre-op mid to prevent complications after surgery. That is also the reason why you have to be very strict telling your patient to do NPO. Observe NPO hours before surgery because you don't want to have complications after the procedure. Okay, so that's the first priority. Check for respiratory functioning. Very good. Okay, Juan, and very good, Arnie Unito. Second priority here is to check your what? Check the patient's vital signs. Okay, check your vital signs. Now, take note how frequent you're supposed to check the vital signs of your patient. Well, that depends, right? Now, take note for a general surgery. Okay, for a patient with a general surgery, take note to check the vital signs every 15 minutes. Okay, every 15 minutes on the first hour post-op. After that, you check vital signs every 30 minutes. Every 30 minutes in the next 1 to 2 hours. Okay, then after that, you check vital signs every hour in the next 4 hours. And then after that, you can do your vital signs on a regular basis. Okay, but nevertheless, on the first few hours, we closely monitor patients' vital signs. So, having said that, take note. Okay, as nurses, you must know the normal parameters of your vital signs. Pay attention with the blood pressure, heart rate, temperature. Or by the way, speaking of temperature post surgery, it is normal to the for the temperature to be slightly elevated post general surgery, okay, but not too high. Slight elevation is okay post case surgery. Okay, pay attention as well to patient's blood pressure because okay, anesthetic drug can cause the blood pressure of the patient to be soft, okay, or blood pressure to be low. Now, speaking of your blood pressure, pay attention to patient's MAP, mean arterial pressure. Okay. Now, what is mean arterial pressure? Let me write it down. What is mean arterial pressure? Mean arterial pressure is the average pressure, okay? Average pressure in a single heartbeat, in every heartbeat. Now, take note the mean arterial pressure is about 70 to 100 millimeters mercury. Okay, this is an average map, 70 to 100 millimeters. Now, take note, make it sure that the map of your patient, okay, is not less than 65. Why? If the mean arterial pressure is less than 65, it means to say the pressure is low, not slow, but low, okay? It will affect perfusion. Okay, so if it affects perfusion, it affects blood flow to different parts of the body. Okay, it means to say it causes a shock. And that is why if there is shock, complication will be organ failure. That is why make it sure that the map of your patient is above 65. But there are also complications. If it's too much, it's not good. If it's too less, it's also bad. That is why if the map of the patient is greater than 100, if the pressure is so high, it's not also good. It increases the risk of stroke. Okay. If the pressure is less than 65, it's not also good because remember, I said less than 65 means low pressure, low perfusion. It causes organ failure. Okay, organ failure. So please do not forget the normal parameters. Okay, third thing to remember, third priority after checking the vital signs, okay, is to check the dressings of your patient. Okay, what will you check, okay, in the dressings of your patient here? Remember, they cut the sternal area, okay, to open the chest wall of your patient. So check the dressing for any bleeding. So you will know that because the dressing of the patient will be soaked with blood. Okay. Number four, after checking the dressing, you check the drains of your patient. Remember, I said chest tube will be placed post surgery. So you should know the normal output of your chest tube. What is the expected output in every 24 hours? We will discuss that in a bit. Okay. And by the way, if you've been following my page, remember I discussed chest tube that was few months ago. Okay, try to check the videos. And of course, the fifth and last priority is to check tubings of your patient. tubing. So please take note, they must come in order or correct sequence. So first thing to do the moment you receive the patient post heart surgery, the first responsibility is to check airway or check respiratory functioning. After that, you check the vital signs, check the dressings, check the drains of the patient, and last to check are tubings. Okay, don't forget those. Number three, third thing to remember post open heart surgery is to evaluate or assess hemodynamic hemodynamic status. Now, what do you mean, Professor, by hemodynamic? What is hemodynamic condition or hemodynamic status or hemodynamic stability? When you say hemodynamic, it refers to uh, circulation, it refers to blood flow. Okay, that's hemodynamic. So tell me, what are parameters that will evaluate hemodynamic stability? Okay, let's identify what are parameters that will evaluate hemodynamic or blood flow circulation. Number one, vital signs. Okay, your vital signs will reflect circulation, perfusion, blood flow. Okay, so I will no longer discuss that. Letter B, another parameter that will evaluate hemodynamic functioning is, of course, arterial blood gas analysis or ABG. Very good, Arnie. Okay, or ABG. Now, your arterial blood gas. Now, if there's such thing as arterial blood gas, there is also what we call venous blood gas, your VBG. Okay, but anyway, the difference is that if it's an arterial blood gas, the specimen is actually from an artery. Venous blood gas, of course, the specimen is from the vein. So parameters wise, if it's an artery, make sure that expect that oxygen is higher than your carbon dioxide. But for your venous, expect that the carbon dioxide is higher, okay, in concentration than oxygen. Okay. But anyway, please be reminded of the normal parameters, values of your arterial blood gas. So you have your pH, okay? What is the partial oxygen pressure, the partial carbon dioxide pressure, then we also have partial. Then we also have HCO3. Oh, I need to erase that. And what does HCO3 stand for? What is this? HCO3, this is your bicarbonate. Okay? So tell me, what is the normal blood pH? The normal blood pH ranges from 7.35 to 7.45. Okay, we know that. PO2, the normal partial oxygen pressure, ranges from 80 to 100 millimeters mercury. Okay? Take note, it's not 95 to 100%. Remember, I am saying partial oxygen pressure. We are not talking about pulse oximetry. We're not talking about O2 saturation. Your O2 saturation is expressed in percentage. Your partial oxygen pressure is expressed in millimeters mercury. Okay? Next, what is the normal partial carbon dioxide pressure? It's about 35 to 45 millimeters mercury. And you have your HCO3 bicarbonate. Normal is 22 to 26 milli, milli equivalent. Why did I write millimeters mercury? Okay, 22 to 26 milli equivalent per liter. Okay, so these are the normal. These are the normal values. Okay, next, letter C. By the way, when you talk about ABG, what is the test that needs to be done before blood extraction? It is a test that will check collateral circulation of the two arteries. What do you call the test? What do you call the test that needs to be done or performed before blood extraction for ABG analysis? You call that test as your Allen's test. Okay, Allen's test. So for ABG, don't forget you need to do Allen's test. Very good, JV Mata. Very good, Allen's test. So your Allen's test will check for collateral circulation of the radial artery and the ulnar artery. Okay, good job. Next, letter C. Another parameter that will check hemodynamic functioning of your patient. Of course, this is an open heart surgery. So post-op, you need to hook the patient in a cardiac monitor. Okay? cardiac monitor. So the patient will be hooked in a telemetry, okay, to check and closely monitor heart functioning. Okay. Now, is heart monitoring your cardiac monitor the same with your 12 lead EKG? Yes or no? Do they present the same data? Do they present the same quality? Your cardiac monitoring versus your 12 lead EKG, are they the same? The answer is no. Okay, no. The data given for cardiac monitoring will give you data for monitoring quality only. But for 12 lead EKG, the data given is a data for diagnostic quality. That is why it's better to use the 12 lead EKG, because the 12 lead EKG will give you the overall picture of the heart, the different views of the heart. But I am not saying that your cardiac monitor is less better than your 12 lead EKG, because in your cardiac monitor, we can see this arrhythmia as well, but not as much as other things that can be seen to a 12 lead EKG. That is why, if you can still remember, if the doctors were ordered for 12 lead EKG, sometimes they will also include with long lead 2 strip to chart. Okay, because your long lead 2 is essential, because among the 12 leads, your lead 2 is the most stable lead. That is why it's the best lead to check for dysrhythmia or arrhythmia. Okay, anyway, letter D. Another parameter that will evaluate hemodynamic functioning of your patient is, of course, your pulse oximetry, your pulse oximeter. Okay, you know the normal value for your pulse oxy? It's 95 to 100%. Okay, pulse oximetry. Next, letter E. Another parameter that will reflect hemodynamic functioning of your patient is your CVP, your central venous pressure. Okay. Now, please be reminded that your CVP, okay, will check right side of the heart. Oh, so your CVP monitoring will reflect right side of the heart functioning. Now, what about the left side of the heart? There's another test for that. So, the left side of the heart is evaluated by PCWP. What is that? Pulmonary capillary wedge pressure. We will discuss that in a bit. Okay, let's focus on CVP first. Your central venous pressure will monitor right side of the heart functioning. Okay, and take note, what is the normal CVP? The normal CVP ranges 2 to 6 millimeters mercury. And take note of the implication. Please be reminded that if the CVP is high, okay, an increase in the CVP would mean hypervolemia. A decrease in the CVP means or reflects hypovolemia. Okay. So again, it will reflect hemodynamic functioning of your patient. Okay. Now, letter F is your PCWP. I said this. Your PCWP will check left side of the heart functioning. Left side of the heart. So don't forget this. Okay, a test that will evaluate right side of the heart functioning is CVP. A test that will evaluate left side of the heart functioning is your PCWP. And PCWP stands for pulmonary capillary wedge pressure. Okay. And what is the normal PCWP? The normal PCWP ranges from 4 to 12 millimeters mercury. And look at the implication. An increase in your PCWP indicates congestion. Congestion. A decrease in your PCWP may indicate shock. Okay. Next, F letter G. Another parameter that will evaluate hemodynamic functioning is your chest tube. Okay, don't forget this. Your chest tube is being placed. Again, for what reason? To prevent accumulation of fluid surrounding the heart, your cardiac tamponade. Please be reminded that the normal or the average drain in your chest tube is, okay, about 200 to 300 ml per 24 hours. Now, I read some journal, okay, some book that if the drainage of the chest tube is less than 450 ml per 24 hours, that is generally safe. Okay, it's okay. Okay, but that again, that depends on the condition of the patient, why chest tube is being inserted. Okay, but what we use general, okay, drainage output is 200 to 300 ml per 24 hours. So if you want to learn more about chest tube, you check my video, okay, where I talk about a one-way bottle system, the two-way bottle system, the three-way bottle system, and I also mentioned the water seal drainage, the plur-evac. Remember that the plur-evac follows the principle of the three-way bottle system. So anyway, check the previous video. Okay. What is this? Jeffrey Ghost mentioned afterload versus preload. What do you mean? You want me to talk about afterload and preload? Jeffrey Ghost, is that what you're trying to tell me? Okay, next letter H. Let's wait for Jeffrey Ghost reply. Okay. Next, another parameter that will evaluate hemodynamic function of your patient is urinary output. Urinary output. Now, please do not forget this in your exam. Okay. Put an asterisk. You have to check urinary output of your patient post heart surgery, especially on the first, okay, 2 hours. Okay. First 2 hours post surgery. Okay. First 2 hours post surgery. Why is it important for us to check the urinary output of the patient post surgery? Remember, one complication of heart surgery, open heart surgery, is what we call cardiac tamponade. Okay. And remember, I said if your patient, okay, develops cardiac tamponade, okay, cardiac tamponade, I said if this is your heart, in cardiac tamponade, fluid surrounds the heart. And as fluid surrounds the heart, it will restrict the normal movement of the heart, the normal pumping mechanism. That is why, because of that scenario, it decreases patient's cardiac output. What will happen if there is decreased cardiac output? Decreased cardiac output will result to decreased perfusion. Okay, decreased perfusion to vital organs. And when I say decreased perfusion, particularly to the kidneys. So this will result to decreased kidney or renal perfusion. If there's decreased flow of blood to the kidneys because the heart is not pumping well, eventually it decreases patient's GFR because of a decrease in the blood flow. So what is GFR? GFR stands for glomerular filtration rate. So tell me, what is the normal GFR, professor? The normal GFR is about 100 to 120 ml per minute. Take note, the GFR is expressed as ml per minute. Okay? Now, I read some journal that as long as the GFR is not less than 60, that's okay. Okay? Because if it's less than 60 ml per minute, that indicates kidney damage or kidney issue. Okay? Now, what will happen if there's a decrease in the GFR? A decrease in the GFR will translate to a decrease in the normal urinary output. So that is why check the urinary output, especially on the first 2 hours post surgery. By the way, what is the normal urinary output? The normal urinary output ranges from 30 to 60 ml per hour. Take note, the unit is ml per hour for urinary output, but ml per minute for the GFR. Okay? Please do not forget this. Okay? I hope this one is clear. So these are parameters. These are parameters that you need to check. Okay, if you want to evaluate hemodynamic functioning of your patient or hemodynamic status. Okay, I hope you learned something. And of course, that's number three: assess hemodynamic status. Okay. Now, with regards to Jeffrey Ghost's question, I don't know if this is a question or he wants me to talk about afterload, preload. Anyway, if he is still around, I don't know. This is for you. I will just discuss this. So he mentioned afterload, and Jeffrey mentioned preload. Now, what is the difference between afterload and preload? Okay, your afterload refers to the resistance. Okay, resistance that the heart needs to overcome. Okay, in order to pump the blood out. Okay, so afterload is the resistance that the heart needs to overcome in order to pump the blood out. The higher the afterload means the higher the resistance that the heart needs to overcome. When the resistance is high, it means to say that the heart needs to work hard. It means to say that the heart needs to exert more effort to pump the blood out. Okay? Now, let's make it simple. Let's draw the heart first. Okay? Jeffrey, I hope you're still there and this discussion is for you. Now, this is your heart. Your heart is divided into two sides, right side and the left side. This is what we call the right atrium. This is the right ventricle, left atrium, left ventricle. Right atrium receives blood from your superior vena cava and inferior vena cava. Okay, the blood getting inside this area is the blood from the systemic circulation, correct? Now, when the heart pumps the blood, take note that the right ventricle, okay, the right ventricle pumps blood going to your lungs. Okay? The left ventricle will pump the blood and that goes to your aorta. Okay? And the aorta will distribute the blood, okay, to the different parts of the body. Simple. That's the normal physiology, right? And the normal structure. Now, what is afterload? Afterload is the resistance that the heart needs to overcome. It means to say that the right ventricle needs to overcome the pressure in the pulmonary area in order to pump the blood out. So, Professor, what is the normal pressure in the lungs that the heart needs to overcome? In the lungs, okay, about the pressure is about, let's say, 20 millimeters mercury. It means to say that the right ventricle needs to pump the blood, okay, pressure of greater than 20, because in the right ventricle will only exert 10 millimeters mercury pressure, it cannot pump the blood out. In order to push the blood to enter the lungs, that pressure exerted by the right ventricle must be higher than the pressure in the lungs in order to pump the blood to enter the lungs. I hope that makes sense. So, this is the pressure that the heart needs to overcome. That is why the afterload of the right ventricle is dependent, okay, in the pulmonary area. Now, take into consideration a patient with bronchitis. What is bronchitis? If you listen to my discussion COPD, you'll be able to answer this one. Bronchitis or itis, suffix itis, is inflammation. A patient with bronchitis has inflammation in the bronchial area. And this inflammatory process can cause blood vessels in the lungs to constrict. That is why when the blood vessels in the lungs are constricted, narrowed, the right ventricle will have a hard time to pump the blood and that blood to enter the lungs because the blood vessels in the lungs are narrowed. That is why a narrowed blood vessel will have a high vascular resistance, which will increase the afterload of the right ventricle. That is why, as a result, the right ventricle will exert more effort to pump the blood because of this condition, resulting to right ventricular hypertrophy or enlargement of the right ventricle due to pulmonary problem. Okay, so that is the afterload, the resistance that the heart needs to overcome. What about on the other side? Left ventricle. The left ventricle pumps blood to your aorta to the systemic circulation. Now, that is the resistance that the left ventricle needs to overcome. If the resistance in the lungs is about 20 millimeters mercury, what is the pressure or resistance that the left ventricle needs to overcome to pump the blood out? Of course, you have your systolic pressure. The systolic pressure of about 80 millimeters mercury. Remember, average blood pressure is 120 over 80. 80 as the diastolic. So the blood pressure or systolic pressure that the heart needs to overcome is 80. So the left ventricle needs to exert an effort, a pressure of greater than 80 to pump the blood out. Because if the left ventricle will not pump greater than 80, it won't be able to propel or project the blood out from the heart. Okay? Now, having said that, if your patient is hypertensive, okay, let's say the blood pressure of the patient is 200 over 160, the diastolic is 160. This is the pressure that the left ventricle needs to overcome because hypertension can cause increase in the vascular resistance. That is why persistent elevation in the blood pressure is not good because hypertension strains the heart. Hypertension increases the workload of the heart that the left ventricle needs to pump harder in order to propel the blood out, pump the blood out because the pressure is so high due to hypertension. That explains why, if you're hypertensive and you're not taking your antihypertensive medication, that will result to left ventricular hypertrophy, enlargement of the left ventricle due to overwork heart. That is why study shows, evidence-based, if your patient takes antihypertensive medication religiously, it prolongs the life of the person. Okay? So again, the afterload of the left ventricle is dependent to the systemic resistance, systemic circulation. Okay? That is the resistance that the heart needs to overcome. Okay? So I hope I answered your question, Jeffrey, about afterload. I hope, okay, that is clear. So afterload is the resistance that the heart needs to overcome. What about preload? Preload is a condition or a state before ventricular contraction, that is right after diastole. Okay. Now, what is preload? Now, look, remember that this is your heart. This is your right atrium. This is your left atrium. Now, when your blood fills the heart, okay, when the blood fills the heart stretches. I appreciate it, sir. Welcome, Jeffrey. The heart stretches. Again, when the blood fills the heart, okay, fills the heart stretches. The heart stretches because of what we call filling of blood. As a result, okay, as a result, when the heart is stretched and fills, okay, the heart with blood, right before, or yeah, filling, correct, one Joseph, right before the heart contracts, okay, just after it fills the heart, okay, right before it contracts, that is what we call preload. Okay, again, preload is the state, okay, state right before the heart contracts, okay, or after the diastole, okay, right before the heart contracts. Again, when the heart fills with blood, okay, it stretches, and if it reaches its maximum stretchability, eventually it will contract, right? So the period, okay, when when blood fills the heart and right before it contracts, you call that condition state there as your preload. Okay, that's it. So, what factors affect preload? Your preload is affected by blood volume. A decrease in the blood volume will decrease the preload. What about afterload? Afterload depends. Are we talking about the afterload of your right ventricle or the afterload of the left ventricle? The afterload of the right ventricle is dependent in the vascular resistance or pulmonary vascular resistance. But the afterload in your left ventricle is dependent to your systemic vascular resistance. I hope that one is clear. Okay. So, anyway, that ends my concept. Your, what do you call this? The concept about open heart surgery, your CABG, your coronary artery bypass grafting. Okay. What time is it? Oh God, it's 2:30 in the morning, 2:13 in the morning. Okay, so I think that's all. And I think I will sleep now. And I will see you again maybe later, wherein we will talk other additional concepts. Okay? God bless everybody. And I hope to see you soon. Oh, there's one more thing here, atrial kick. Urgh. I will discuss that next time. Okay? Thank you so much, everybody. God bless. And I hope you learned something. Keep safe. Ayaw nyo mag-off. There. Thank you and rest well. Yes, I will. Bye, everybody. Keep safe.